In today's class, we will discuss about chronic dacryocystitis, its etiopathogenesis, signs, treatment of DCT. So, what is DCT? It is a chronic long-standing inflammation or an infection of lacrymal sac. So, lacrimal sac is located in the lacrimal fossa, which is there, whereas dacryoadenitis is the inflammation of lacrimal gland which is present in the upper eyelid, right? So this is dacryoadenitis versus dacryocystitis. Coming to the etiopathogenesis, the etiology is the infection can be caused by organisms such as staphylococcus, streptococcus, and pseudomonas, and in chronic granulomatous infections such as tuberculosis, sarcoidosis, leprosy, and all. So these are transferred from the adnexa, that is, from the conjunctiva, from the maxillary sinus, the sinuses, the paranasal sinuses, and all. From there, these organisms come and infect the lacrimal sac. And the predisposing factors for to get infected can be either like reduced immunity, and in case of nasal diseases, and there can be some anatomical factors, right? So we need to rule out these nasal diseases such as nasal polyps, hypertrophy of turbinates, and severe deviated nasal septum, atrophic rhinitis, etc. So we need to rule out this first. And the anatomical factors include a narrow bony canal through which this necrolacrimal duct and the lacrimal sac are situated, and if there are excessive folds in the nasolacrimal duct, or if there is a partial canalization of nasolacrimal duct. Okay, so this narrow bony canal is seen most commonly in the females because this is physiological. That's why most commonly it is seen 80% in females only, and in 40 to 60 years of age, because there can be some debris which can block the nasolacrimal duct and cause chronic inflammation. So these are the predisposing factors. Now coming to the symptoms and signs. So they present with watering discharge commonly, and the signs can be divided into the stage of presentation. So there are 4 stages of presentation. So the first stage is stage of catarrhal dacryocystitis, the stage of lacrimal mucocele, then is the stage of suppurative dacryocystitis, and the final fibrotic sac. Coming to how to differentiate this all, so based upon the symptoms, based on syringing and dacryocystography, we can find in which stage the patient is there. So in catarrhal dacryocystitis, the patient presents with a watering discharge, whereas in the mucocele there is constant watering and discharge and distension of the sac. So you can see a rounded area near the medial canthus. In suppurative one, we can see a swelling, and along with that there will be conjunctivitis because there is infection. In the fibrotic sac stage, there will be constant watering and discharge from the eye. On syringing, there will be clear fluid regurgitation in catarrhal stage, mucoid fluid on pressing near the middle canthal area, that is regurgitation test. In suppurative one, actually the syringing should not be performed, and on pressing we will see a frank purulent discharge. On And on dacryocystography, the catarrhal stage reveals blocked nasolacrimal duct, and in the mucocele stage also there will be a blocked LLD along with the distended sac, and it will be almost similar in case of suppurative one, and whereas in case of fibrotic stage there will be a very small fibrotic sac. So these are all the 4 stages and signs of chronic dacryocystitis. Now coming to its complications, so because it leads to infection, the infection can spread to other areas near the eye. That's why we have to perform Roplas or syringing before doing any ocular or adnexal procedures. So Roplas indicates regurgitation on pressure over the lacrimal sac area, or syringing. So these are the must before any intraocular surgery, because there is a very high risk of endophthalmitis if this is not addressed. Now coming to the treatment part. The treatment is either dacryocystiectomy or dacryocystohinostomy. So first the dacryocystiectomy. So DCT, the indications. So it is indicated only when the DCR is contraindicated. So if the age is less than 4 years, or if it is very elderly, in case of fibrotic sac, in case of tuberculosis, syphilis, leprosy cases, and in case of tumors of the lacrimal sac, and in case of very severe nasal diseases such as severe DNS, where DCR cannot be done. So this is usually not performed because there is a constant watering post surgery. So the steps of these include, we will identify the sac area and give a J-shaped incision over the lacrimal sac area. Then we will dissect it. We will see where is the anterior canthal ligament, where is the lacrimal fossa, and then the wall of the sacs and all are identified. After that, we will dissect it from its adhesions from the lacrimal fossa, and we will remove the sac, and the inferior edge of the nasolacrimal duct which is remaining will be probed or curated. So these were the steps of lacrimal dacryocystiectomy. Then the wound is closed in 2 layers. Coming to what is DCR, that is dacryocytorhinostomy. So based on how it is performed, it can be divided into external, endonasal or endocanalicular, and endonasal can be divided into surgical or laser. Coming to what are the steps of external DCR, are remain almost similar to that of DCT, but at last, instead of removing the sac, we will just open the sac and stitch it to the nasal mucosa, so that the fluid is drained into the nose, and through which it goes into the nasal cavity, larynx and all. Okay, so this is the external DCR. So we give an incision, and after giving the incision, medial palpebral ligament and anterior lacrimal crest are identified. Then we will dissect the lacrimal sac from the lacrimal fossa. After that, the nasal mucosa is exposed. So here we have a very important step. that is creation of a bony osteum. Okay, so to go into the nasal cavity, to create a communication between the lacrimal sac and the nasal cavity, we have to create a bony osteum. So here lies the major difference. So this is usually of the size of 15 into 10 millimeters. So I will depict you in the form of a diagram. So let us consider this red one is the lacrimal sac. We will create an opening into the bony osteum through which it will go into the nasal cavity. So we create a mucosal flap by giving a vertical incision. So it will divide it into two parts, right? And the one part is sutured, one flap is sutured to the nasal mucosa, and the other one is to the sac. Now, after creation of this, we close the incision. So in this way, we are creating a communication between the lacrimal sac and the nasal cavity through a bony osteum. Coming to endonasal DCR. So in this, it is done through the nasal cavity and not from the external. So there is no external incision over here. We go through the nasal cavity and we create a bony osteum, and through this bony osteum we will create a stent which goes and inserts into the canaliculus. So from the canaliculus, the stent will drain the fluid into the nasal cavity. So some people also avoid stent. So without stent also they keep it like that. And in case of laser endonasal DCR, we use a holmium YAG laser or KTP laser to create the osteum. And in endocanalicular, we use a diode laser. So endocanalicular, in this, the fiber optic cable, instead of going through the nose, it will go through the canalicular, right? So this fiber optic laser, it will go through the canaliculus, and from there it will go into the sac, and in the sac it will create an opening. Okay, from there it will go into the nasal cavity. So coming to what is this osteum and where it should be exactly placed. So this osteum plays a major role in this DCR procedure. So it should be placed near the inferior part of lacrimal bone. Ideally it should be 6 to 8 mm. In case of laser DCR, it should be large. Whereas in case of external DCR, 2 mm is said to be enough. Okay, so it can also apply mitomycin C 0.5 mg per ml for 10 minutes to reduce the inflammatory reaction, and this inflammatory reaction in turn lead to reduction in the size of the osteum, right? So this is the most common reason for failure. Now coming to the advantages versus disadvantages of endonasal versus external DCR. So advantage is that there is no scar and there is less disruption of the medial canthal ligament and the lacrimal pump, and the operative time is less, and there is less bleeding, early recovery of the patient, and there can be a simultaneous treatment of the nasal pathology also if it is present. So this is performed by ENT surgeons also. Okay, so these are the advantages, and the disadvantages is that it is a costly procedure and the learning curve is more, and there is reduced nasal mucociliary clearance due to damage to the nasal mucosa. And also there is a risk of failure if the osteum is not properly sized. So we'll discuss it in the complication part. So the complication includes the most common one, as we said, is the failure of the procedure. So this usually occurs by 1 to 3 months. So it is due to progressive cicatrization closure of the osteum, because this laser and all, they create a intense tissue reaction. It can also occur if there is the stent gets impacted with some materials, if there are any adhesions which are formed between the osteum and the middle turbinates, or the osteum with the nasal septum, and also if there is formation of an granuloma, that is an excessive tissue response. Okay, so these are all the causes of failure. So other complications include punctal erosion and silicone turbine prolapse, thermal injury to the canaliculi if we are performing a endocanalicular procedure, and they can be orbital or subcutaneous emphysema when when the patient coughs or applies more pressure valves or maneuver, they can be this thing. So thank you for watching. This was regarding the DCT, DCR and chronic dacryocystitis.